Welcome back, everyone, to part 96 of our Explainer series. Today, we are diving headfirst into the incredibly high-stakes world of evaluation and management coding, or EM coding for short. As a medical coding instructor, I can tell you firsthand that getting this right, well, it's literally the difference between maintaining healthy practice revenue and walking straight into massive compliance risks. We're going to cover everything from the bedrock foundational rules all the way to how artificial intelligence is completely upending the traditional auditing process. So let's just get right into it. Here's our roadmap for today. First, EM coding and guidelines. Second, mastering modifiers and necessity. Third, the internal auditing process. Fourth, managing denials and appeals. And fifth, the AI revolution in auditing. Let's kick things off with Section 1, E&M Coding and Guidelines. These are your foundational rules. So, the American Medical Association CPT guidelines, they are the absolute Bible for EM billing. Back in 2023, these guidelines went through some major revisions to really streamline how we document a whole host of services. We're talking hospital, inpatient, outpatient, observation care, consults, ER visits, and even nursing facility services. The basic format here defines the place of service, the content of the service based on either medical decision-making or time, and it ensures your documentation perfectly reflects the exact care you actually provided to the patient. Now, an absolutely crucial point to grasp right out of the gate is the strict 3-year rule. This rule dictates whether a patient is classified as new or established. And honestly, it's not just about whether the doctor remembers seeing the patient. A new patient is someone who has not received professional face-to-face services from any physician of the exact same specialty and subspecialty within the exact same group practice in the past 3 years. This distinction is huge because it directly impacts the E&M codes you end up choosing, though keep in mind there is one major exception. In the emergency department, we actually make no distinction between new and established patients. Moving right along to Section 2, Mastering Modifiers and Necessity. This is how you safeguard your claims. Modifiers are absolutely critical. I want you to think of them as special little flags that you attach to your claim. Technically speaking, a modifier is a 2-digit code added to a CPT code to give extra context without actually changing the core definition of the service. For instance, you'd use modifier 57 when an EM visit, say an abdominal exam for severe pain, leads directly to a decision for an emergency surgery that same day, like a laparoscopic appendectomy. Or take modifier 25, which you use for a significant, separately identifiable EM service on the exact same day as another procedure. Getting these right is how you prevent inappropriate bundling and ultimately those dreaded denials. But here's the thing. Modifiers mean absolutely nothing without medical necessity. CMS defines this as services that are proper and needed for the diagnosis or treatment of a medical condition. Without this documented necessity, even the most flawlessly coded claim is going to get denied. No way around it. You could have your CPT codes perfectly aligned, your modifiers spot on, but if the patient's severity of illness doesn't match the intensity of the service you billed, like, say, coding a common cold as a level 5 visit, the payer is just going to reject it. Medical necessity is, without a doubt, the overarching criterion for payment. That brings us to Section 3, the internal auditing process. Let's talk about catching coding errors before they catch you. You see, auditing isn't just about hunting for mistakes. It's really about revenue integrity. Undercoding, like if you document 3 chronic conditions but only bill a 99213 instead of a 99214, that quietly just drains your revenue. On the flip side, overcoding to a 99215 when you only have minimal documentation, that creates a massive compliance risk and forces paybacks. And if you have a pattern analysis that shows you're frequently using the high spilling levels, that anomaly is going to instantly put you on the radar of the Office of Inspector General, the OIG, as a giant red flag for potential fraud or abuse. When you run prospective audits before you bill or retrospective audits to check your trends, you're going to see a few common pitfalls. Things like missing medical decision-making elements, copy-pasting or cloning notes, which, by the way, auditors absolutely despise, and improper use of modifier 25. Seeing these issues pop up highlights exactly why regular quality assurance checks, like random monthly chart audits, are so incredibly vital for your practice. It keeps your accuracy percentage high and keeps you far away from the OIG's radar. Okay, let's jump into Section 4, Managing Denials and Appeals. Here's how we handle those inevitable rejections. When you're fighting a common CO50 denial, which specifically means they denied it based on medical necessity, you have to follow some precise steps to craft an airtight, evidence-based appeal letter. Steps 1 and 2 just set the stage with your basic info, but Step 3, that is your battleground. That's where you explain the clinical necessity and directly cite the 2023 EM guidelines or the payer's own policy. And step 4 is crucial because without supporting attachments like progress notes and diagnostic results, your argument is really just empty words. Following this exact structure forces the payer to reconsider the claim based on hard clinical facts. And finally, Section 5, the AI revolution in auditing. This is the true evolution of the revenue cycle. It is genuinely fascinating how large language models, think GPT-4, Google MedPalm, or Anthropic Claude, can basically automate this entire workflow now. First, the AI flags that CO50 denial. Then it instantly pulls the Medicare local coverage determination or the specific payer policy right along with the patient data. Next, it drafts a fully customized, perfectly structured appeal letter in literally seconds. Finally, a human auditor just steps in to review, validate, and submit it. It's like having a real-time compliance guardian on your team. The capabilities of these tools are completely transforming the process. Because the AI maps directly to specific payer policies and uses evidence-based clinical terminology, it drafts highly persuasive arguments tailored exactly to what the payer needs to hear. And if you're worried about privacy, don't be. These systems operate on highly secure, HIPAA-compliant cloud platforms like Azure. Using this tech drastically improves win rates on those incredibly complex medical necessity denials. It's a real game changer for revenue cycle management teams. The most crucial takeaway from this whole technological leap, we are seeing a massive 50 to 60% reduction in manual appeal drafting time. I mean, just imagine what your coding staff could accomplish if they got half their day back instead of sitting there manually typing up appeal letters from scratch. So, I want you to take a hard look at your practice. Is your current coding workflow leaving revenue on the table, or worse, inviting an audit? Because really understanding EM guidelines, mastering your modifiers, and embracing this new auditing tech, it isn't just about compliance anymore. It's about securing the financial future of your healthcare delivery. If you aren't adapting, you are definitely leaving money behind. Thank you so much for joining me for this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.